Thank you very much indeed. Thank you, Shahid, again for the invitation to come to Karachi. It's now my fourth time, and I really do enjoy coming here and learn a lot as well. So I'm just going to talk about acetabulum and just sort of how we're really have seen the game changer really in how we deal with acetabulums. You saw a very nice acetabular reconstruction in the live surgery, but it was a relatively straightforward hemisphere that was nicely dealt with a large 60-ish serve cup with a hydroxyapatite. But sometimes you don't quite get those hemispheres. You've got oblong defects that you need to better deal with. This is just some stamps that came out in my country at the turn of the century, just highlighting achievements in medicine in the 20th century. And this was the stamp highlighting the achievement of the hip surgeon. I think you can see that the trochanter's broken, the acetabulum has got lots of lysis. This is a failed hip. And I don't think that was doing the hip surgeon justice. So the UK hip surgical community made a complaint to what we call the Royal Mail. And I'm happy to say that 2 weeks later it got changed to that. A nice pristine hip replacement. And what this I think shows is, the hip is the best operation we do. But when it goes wrong, it can be very challenging. And I think that you saw in that live surgery, a relatively straightforward revision, just had its difficulties, had its stressful moments, because we didn't maybe have every single bit of inventory that we could have had. And you saw how you have to compromise sometimes. And that compromise can sometimes make revision surgery quite a nerve-wracking experience. That was a really good sort of lesson, I think, in doing hip surgery there. The predominant cause of why we revise hips is aseptic loosening, as seen on my registry, the National Joint Registry, and also the Australian Joint Registry, with instability, infection coming a second and third place. And we've got a problem in the Western world, and you'll have a problem as well. You are still putting in the old-fashioned polyethylenes. And so we're going to be seeing in all around the world this increasing number of hip revisions and also knee revisions increasingly happening, especially as we are able to treat these cases more and more. But the bottom line is we are not as good at revisions as we are at primaries. The results of revisions are inferior to primaries in a lot of series. And this is why. This is what we're dealing with. This is the acetabulum. So the guys who haven't done much revision surgery, just imagine that. That is got no medullary bone left. That is corticated, thin, fragile. The blood supply is maybe quite poor. The biology is damaged by either osteolysis, infection, or in my country, metal on metal. So we've got a very fragile biological situation here that we've got to invigorate back to life. And that's the skill of a revision surgeon. We could ignore this and just put a cage, some screws up here, some screws up there, and bypass this. But we're not thinking about that now. We're trying to breathe life back into this poor quality bone. This bone won't take cement, will it? There's no medullary bone to take cement in here. So all you've got is to try and get some form of fixation which is going to actually encourage bone to grow into it to make this durable for life. And this is from the National Joint Registry, just showing really how the years that the re-revision rate, as you go up, as you go down in time, at 10 years, you've got a 50% chance of needing to revise a hip again. So we've got to try and stop this vicious circle of revision and revision and re-revision. And this is from the Norwegian registry, a large series. Quite a high primary failure rate, but look at the re-revision rate at 10 years, 28%. Look at the re-revision of that revision. Look at the re-revision. You can see that we're not stopping this downward spiral of ever-decreasing success rates with our revision, because we're not understanding the biology of that poor quality bone that we're dealing with. Now, there's a number of different options, and you've seen a few in your practice, I'm sure. Cages, impaction grafting. The big problem is the 3A and 3B defect, as described by Proposky. The big bone losses. This is an impaction grafting paper. You can see the big drop-off in the success rate of the more severe defects. The 1s and 2s do well, probably, with just hemispheric cups or a bit of impaction grafting. But it's hard when you get the bigger defects. And so Proposky has described this algorithmic approach to dealing with the acetabulum, looking at the X-ray first to guide you on the classification, and from that classification to guide you about what actually you're going to reconstruct. And so the X-rays are key, and you can visualize a lot of the problems from the X-ray. So I'm just going to guide you a few landmarks to look at when you look at an X-ray of a failed hip. Try and visualize it as a three-dimensional structure coming out of this two-dimensional X-ray. First of all, draw that line over the top of the obturator foramen and try and get an idea of how much migration there is of the femoral head. So they say that the 1s and 2s have less than 3 centimeters migration. The Proposky 3 cases have more than 3 centimeters. So be thinking about how much migration there are. So measure that line there. If it's more than 3, it's likely there has been some movement of the femoral head and cup superiorly. And that would then consider that be a Proposky 3. Look at the ischiolysis. That tends to give you an indication of the integrity of the posterior wall. Draw this line called Kohler's line, up from the lateral edge of the obturator foramen up through the sciatic notch. If the shell transgresses this Kohler's line, you know you've got loss of integrity of the medial wall. And then the final thing is looking at the teardrop. The teardrop often gives you an idea of the integrity of the anterior wall of the acetabulum. I tell you what, if you look at a lot of your X-rays, there's a lot actually have completely normal inferior bone here. You will often see a teardrop. You will hardly ever see ischiolysis. This is where the damage is happening. So this is often pristine bone that sometimes has never been touched. So I ask you, think about using it, because it's the best bone you often have in these more severe defects. So this all comes into the Proposky classification. The 1 to 2A, 2B, the 2C is a more medial defect going through Kohler's line, and then you've got the 3A and 3B. 3A is up and out, higher than 3 centimeters. 3Bs are up and in. And then you have a pelvic discontinuity as maybe a type 4. I'm sure you've heard about this, and I won't labour the point anymore. And then you've got the use of augments to try and reconstruct your bone defects. And you can use these augments in various different ways. What you're trying to do is to reconstruct the hemisphere. And you can use it in this standard oblong defect if you've got a contained defect, but just some superior bone loss. But if you've actually got an uncontained defect, you may want to put the buttress, turn it over, and use it as a buttress, and actually place it on the bone rather than this configuration within the bone. And then you can also put the augments together in a wheel formation, which we call footings. You put some cement between the ends of the augment, and you can wedge them into a medial defect like a cork in a wine bottle. So this is a remarkable versatility for you to come up with solutions. And what you're trying to do is to make the hemisphere to fit your cup. There are some other systems out there that make the cup fit the hemisphere. Here, you're trying to make a hemisphere to get a 3-point fixation of your cup. And for instance, this is a cage reconstruction after fracture. And when this patient had a lot of mechanical pain on walking, and when we went in, it was only the screws holding this non-biological fixation cage in place, and it easily was able to be removed. And then we worked within the defect, that poor quality bone. We got our cup positioned down inferiorly on the teardrop, we put an augment superiorly, and we're getting the implant fixing in that acetabulum and loading on that acetabulum, trying to bring life and invigorating that bone again, rather than bypassing it, which is what the cage does. This is just a sort of how we do it. I think it's been quite valuable for you to see this video, so forgive me for going a little bit long, but that's how we dealt with these defects with a superior augment. So this is the acetabulum, this is the femur here, and I'm reaming up now between the ischium down here and the pubis there. And I've now got the right size of the cup. You can't move that reamer, translating anterior or posterior. That is the size of the cup. That's a nice retractor, that's the inferior retractor in the obturator foramen, making sure that you're clearing out all the soft tissue down to the teardrop. So I always try and put that retractor in to get you low so that you can see the inferior bone. Then we're going to put a trial in. We didn't actually see the trial in Tabir's case because it looked like a hemisphere. But you probably would have used a trial and probably would have found good fixation. And here I've got good fixation front to back on this trial. But you can see there's a defect up there, and it doesn't take much on this handle to show that you haven't got that 3rd-point fixation superiorly. You've got good fixation here, but you need to have more fixation superiorly. If you go bigger, you could blow out your ischium or pubis, and then you've lost your 2-point fixation inferiorly. So here we are, we're just going to freshen up the superior bone now, just to clear it up of any soft tissue, just to get it sort of some fresh bleeding bone. You can see that's superior. And then we're going to put an augment in there to show you how easy it is now to get that 3rd-point fixation. The key thing is you've got a whole range of different sizes of augments. You've got them from 50 to 70 millimeters in circumference. And you've also got from 10 to 30 in thickness. And this is a 10 millimeter thick augment. What you're trying to do is to maximize your host bone contact on the augment. If it's too big, it won't fit. If it's too small, you're not maximizing your host bone. You want as big a surface area of porous metal to allow bone to grow in. And you can see this is probably the right size. You can see we've got that 3rd-point fixation now on our shell. So we think that's the right size. So just go as big as you can. You'll know when you're too big because it won't fit. And then we're going to now put the proper augment in. This is a porous augment made of trabecular metal. The material is tantalum. We're going to just sort of wedge it on top of the cup. The great thing about these augments is that they have a high coefficient of friction. They've got struts of tantalum that dig into that poor quality bone that we see so clearly. So all you need is a little bit of compression on one screw and you'll get a very solid component because it's got such a sticky surface on which the bone. So I'm just fixing it. And then I'm going to put a screw in there. I'm just tightening a screw, and look how solid that augment is now on the bone. It's been compressed onto the bone, and it's like it's so sticky that that's all you often need, just one screw. Why I try and often just put one screw in is that this window here on the augment is where the posterior column screw is going to go. So when I put my cup in, I'm going to try and put my posterior column screw up through that window, up through the posterior column. Now if I put a screw in that hole, I'll block my window. And I try and keep these windows free of screws until I've got my cup in. When the cup is in, I can then put that screw in. But see, that's a relatively anterior screw, and you can see how solid it can make that augment. So what we do is we put some cement just on the augment, and this cement works in two ways. I think it works as a lubricant, just to allow the struts of trabecular metal on the two surfaces. This is a TM modular shell, and that's got porous metal on the back. It acts as a strut, and it's just going to allow the surfaces to glide over each other. Plus it cures, and then you're unitizing your shell onto your augment with cement. And I'm just impacting it there, and you can see there's going to be a little bit of cement just between the augment and the cup. And that will give you a bit of unitization, making this essentially a custom-built oblong cup. But it's so custom, it is maximizing your host bone contact onto the porous material. And then we're just impacting it there, and we get a really satisfying feel often. And it's got to be a press fit. It's not good enough just to have screws here to support it. And then we're just going to finally put that posterior column screw up through that augment window to again unitize the shell onto the augment into the bone. And you make a very strong construct here. And then finally, we can put another screw in that hole of the augment, which we have kept uncovered while we put this posterior column screw up. So this is probably the skillful bit, just to get the windows aligned with the holes in the cup. Occasionally when we've got more severe defects, we use these things called buttresses, which are the more severe uncontained defects posterior laterally. These are buttresses which again lay on the bone to allow us to recreate our hemisphere. Just to reiterate about that inferior bone, look, this is a really difficult case in a rheumatoid arthritic girl. But look, you've got bone here, you've got a teardrop, you've got ischium. So this case, they actually was done in another hospital, but they actually failed to get a TMARS in. So they sent it up to me to have a go. But also, look at this case. This case has been put too high. We're missing bone here. So in a case like this, it's not surprising that this case failed, because we're missing out this inferior bone. So in that case down here, the rheumatoid lady, when I went in there, I made a big effort of putting that inferior tractor in. That's the femur. This is a hole, but I went low with my cup and got a cup in here. That's the big defect, which I ignored until I got my cup size. But once I got the cup size, I could put whatever augment was giving that third point fixation superiorly. And that was a construct, with the cup nicely on that inferior bone being supported superiorly. And that's a cement between the cases. And occasionally, you do need to sometimes drill some extra holes. And I use a Myodex Rex to do that. So I just want to emphasize the failures that I see in using TMARS are often this. They've gone too high. They've gone too high and ignoring bone like here. So try and go low, clear it all out, and find the teardrop in the ischium and get a good press fit in between. And that was her walking about 3 months after being partial weight bearing, which we got her up. Sometimes you've got quite severe defects. These are called the 3Bs now. These are up and in. The bone loss is bad, the Kohler's line is violated, and they often do have inferior lysis. This is a defect, this is a bone model. And what we're doing here is using this as a keystone augment to make sure the cup is pushed down onto what remaining inferior bone we have. And then we can sometimes lock in that posterior lateral defect with a buttress. And this is quite a common construct I do for the 3B defects. And you can get that. Now sometimes you need to actually get some inferior screws And so to get that, you need to actually take the rim of the cup off. Now this is actually a revision cup. This is a fully porous cup that you don't actually unfortunately have in Pakistan at the moment. I hope you will get it because it's fully porous and it's got the elasticity of modest elasticity of bone, and so it loads bone very nicely. But sometimes I do have to take the rim off, and then you can make new holes in this trabecular cup to get some inferior screws, like in this case, where I'm getting some inferior screws down here to support it and avoiding having to use a cage. So I think that trabecular metal really allows you to get immediate structural integrity into your acetabular defects. It just seems to have some incredible biological ingrowth potential if it's kept stable. And it can only be kept stable by 3-point fixation and judicious use of screws. But it gives you a very good initial stability, allowing the 6 weeks or so for hopefully bone to get invigorated and grow into it, to try and stop this vicious circle of re-revision, re-revision, etc. And I use it extensively in both my acetabular defects, both revision and even oncology cases. I think an algorithm with an X-ray trying to work out whether it's a simple 1 or 2A, 2B defect, that can just need a hemisphere. A 2C will need a footing. A 3A and 3B will need some of the augments that I've shown you. I think if you have poor inferior or even anterior fixation, think about making sure you get some inferior screws or use a cut cage. And you're just trying to optimize the host bone contact and trying to get a biological reconstruction. And the nice thing about it is, by going low, you're also restoring the hip center and you're optimizing the patient's hip biomechanics. So you're always getting two bonus points for using this technique. Thank you very much.